whether our slides can be shared and
Ma'am, actually,
We are
we'll go
live,
live
yes.
in
We are
a few
live.
seconds. Okay. Very good evening to everyone. It's an absolute pleasure to welcome you all to the inaugural session of AIOS GuruSangam 2025-2026 edition, the Teach Fest initiative by All India Ophthalmological Society. More to educate, elevate, and excel, it reflects our commitment to fostering a community of ophthalmic educators who will help everyone shape the future of eye care in India. Let's take a moment to appreciate the significance of Guru Sangam. Well, in Indian culture, a guru is a revered guiding light, and Sangam represents a sacred confluence. So, Guru Sangam is a beautiful confluence of gurus, symbolizing the coming together of minds that share the wisdom and pursuit of excellence. It's a platform where experienced educators and aspiring teachers are converging to share knowledge, the best practices, and innovative ideas. And our theme for today's session is refraction, a fundamental aspect of ophthalmology. We thank the respected AIOS dignitaries for designing this session and taking this wonderful initiative. We're privileged to have our five distinguished speakers and our four expert panelists from across the India who will share their expertise and insights with us. Just to introduce our speakers, I would say Dr. Vikas Kanoija. He is currently working as professor since 2017 and is heading the department of SGPGIMS since 2022. And after finishing his undergrad and postgrad from Meerut, he trained in neuro-ophthalmology for 3 years as senior resident, and after that joined neuro-ophthalmology department at SGPGI as assistant professor. He did his short-term training in vitreoretina as well, and further trained in Belgium and Malaysia. He also trained in refractive surgery under the guidance of Dr. Rans Reinstein. He has been an instructor and co-instructor of neuro-ophthalmology courses at various conferences and has been moderating and presenting at various platforms as well. He is a reviewer and evaluator of your free paper and IC courses for neuro-ophthalmology and medical retina and refractive surgery at AIOS since 2017, and he'll be talking on clinical optics. Our next speaker is Dr. Kavita V. She did her MBBS from JJ Medical College, Davangere, Karnataka, and did her DO from Karnataka as well, followed by DNB from Tamil Nadu. And she did her fellowship in general and pediatric ophthalmology from Coimbatore, and she finished her ICO Part 1 and 2 in 2005 and did an observership in strabismus at Ames. She finished her MCH ophthalmology from Seychelles, and she has presented various papers and posters at various platforms and is reviewer for IJO, SJO, and other journals. She's also the editor of Karnataka Ophthalmological Society Journal since November 2023 till now. And her areas of interest would be pediatric and adult cataract, low vision aids, neuro-ophthalmology, bioethics, research, and teaching. She's won the Best Video Award, the Best Pediatric Paper Award at COSCON, and she's also won the prestigious Dr. Krishna Prasad Kudlu Award in Community Ophthalmology, and she's a teacher par excellence. Welcome, ma'am. And she'll be talking on understanding cycloplegics. We have our next speaker, Dr. Natasha Radhakrishnan. She did her MBBS from TVM Medical College with 3 distinctions, 2 gold medals, and also Kerala University third rank. She did her MS in DNB from Trivandrum, and she went on to take the All India Gold Medal for DNB Ophthalmology in 2001. She is actively involved in teaching MBBS and MS students since 2007 and has been a faculty at the Medical Education Department. She's actively involved in training the Retina Fellows and is a known speaker at the state and national forums in retina and uveal diseases. And she's an invited speaker at Telangana Ophthalmic Club, Pediatric Rheumatology Society, and uveitis meetings. She has won several awards. She is Distinguished Teacher Award by Federation of Teachers of India in January 2004 and Women in Leadership Award in December 2023. Her areas of interest would be uveitis, diabetic retinopathy, and other medical retinal diseases. And she's passionate about ROP and is helping in prevention of ROP blindness. We have our next speaker, Dr. Nawab Farooqi. Dr. Nawab Farooqi completed his graduation and post-graduation from MAMC and associated GB Pant and Guru Nanak Eye Center. He did his FACO fellowship in 2003 from LVPI Hyderabad. Currently, he's teaching faculty professor and head at Haryana, that is Maharaja Agrasen KNG Medical College, and he worked as senior consultant ophthalmology at Deen Dayal Udaya Hospital, New Delhi, till 2004. And he's worked as academic in charge, guided postgraduate DNB students in their research work, and has guided them for surgical skill training for almost 2 decades. Completed 15 theses as guide. He's been a subject expert at NBE and is a thesis evaluator, examiner for DNB, theory evaluator, and practical OSCE expert, and also accreditation expert for for NBE. He's performed more than 20,000 phaco surgeries, and his field of interest would be toric IOLs, astigmatism, and phaco-dynamics, phaco-emulsification. We'll be talking on cross cylinders, principle, practice, and clinical relevance. And our fifth speaker is Dr. Pradeep Kumar Saraf sir. He finished his MBBS from Gorakhpur and MS from Calcutta University. And he trained in vitreoretina, training in lasers and fluorescent angiography at Shankara Madras. And he also did fellowships in Germany and phaco training at LBPI Hyderabad. He was attached to Vivekananda Hospital, Calcutta as eye bank in charge from 1987 to 1990, and he's done about 50,000 cataract surgeries. And he's also a visiting ophthalmologist at a non-profit charitable institute and is also the professor department of ophthalmology at Vivekananda Institute of Medical Sciences, Kolkata. And he's been an MBBS and MS examiner since 2015 and is practicing general ophthalmologist since 1986. And he'll be talking on approach to a patient in OPD. With the amazing panel that we have, I'm sure that we will be able to cover the various topics. And all these topics will be covered on refraction, and we hope to provide a comprehensive understanding on the principles and practices of refraction to help you elevate your teaching skills. And Dr. Farnaz Khan from Center for Sight in Hyderabad, and I, Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur, Rajasthan, will be moderating today's session. So, without further ado, let's begin our first session on refraction. And I hope you find the discussions insightful, thought provoking, and enriching. So, I request our first speaker, Dr. Faruqi sir, to please share your screen.
Am I audible?
Yes, sir, you're audible, sir. The
Can I
screen
start?
is also visible. Yes, sir, please go ahead.
Good evening, and thank you, Dr. Bansal. Okay, I'll start with my presentation. I'll be speaking on the cross cylinder, the principal practice, and the clinical relevance. Now, astigmatism. To understand the cross cylinders and its principle, it is important to take a brief look at the basic concept of astigmatism. Now, if the image of the point object as found by an optical system is itself a point, is called stigmatic image. Now, astigmatism basically is a combination of the article A in English meaning without and the Greek word stigma meaning point, indicating the concept of without a point. Astigmatism basically is
So
without a point.
may I interrupt, sir?
Yeah,
Sir,
sure.
could you please click on the hide button on the screen? Right,
Fine.
sir.
Okay.
Perfect, sir. Thank you.
Okay. So astigmatism basically is a combination of the article A in English meaning without and the Greek word sigma meaning point, indicating the concept of without a point. Astigmatism is basically a concept without a point. It forms a different image, which I'll shortly be discussing. Now, on stigmatic or non-stigmatic or astigmatic image basically results from the light passing through a lens system that is not a spherical surface. Now, regarding the cylinder imagery, the cylinder is the simplest form of an astigmatic lens. In a cylindrical lens, one meridian is curved, and the one at the right angle has no curvature at all. The image formed of the point object is not a point but a straight line. The rays passing through the axis are basically unrefracted. It passes straight through because it's a plane surface. It's only the meridian where it's a curved surface perpendicular to the axis that the image is formed because of the refracted rays. Now, Kunoda-Strom is one of the most important aspects for understanding astigmatism and the various aspects associated with it. Now, astigmatism results from when both the meridians are curved but to a different in degree. As a result of the difference in corneal curvature in both the meridians, the rays of light do not have a point focus on the retina. Instead, there are 2 points of focus. The one which are higher Corneal power is focused anteriorly, as for example, in this case is F1, the anterior focal line, and the one with the lesser curvature forms much further away, that's F2, the posterior focal plane. The distance between these two focal points lines F1 and F2 is termed conoid of Sturm. As in this case, it can be seen the horizontal line is more curvature and has more power. Hence, it is the image is formed at F1, and we have a horizontal line, and the vertical meridian, which is more curved with more power, with less power and less curved, is flatter. It forms much further away at F2, and it forms a vertical line, which is the axis of the this vertical path. Now, the circle of the least confusion of diffusion is one of the very important aspect of the stream of conoid. In this, we can see that the horizontal curvature, which has more power, which is more curved, forms at F1, and a horizontal line is formed. And the vertical, which has less power or less curved, forms an image at F2, which is a vertical line. Now, at a point where the horizontal and vertical rays they intersect, forms basically a circle of the least diffusion or confusion. Now, this small circle that can be formed by the ocular refraction is called the circle of least confusion or diffusion, and this is one very important aspect where the whole system of astigmatism correction is based upon. And this is the point which is midway between the F1 and the F2, that is the anterior focal line and the posterior focal line. And this is the point which is basically this spherical equivalent also. The circle of least confusion is the closest an astigmatic eye can come to achieving a clear image. Now, vector addition is one of the most important aspects if one has to understand the basic concept of astigmatism. Otherwise, it's very difficult because it's not a scale. Astigmatism is basically a vector which has both magnitude and direction in the form of axis or meridian. Now, fundamental to any understanding of combination of astigmatic vectors or cylinders in any clinical setting, it is the resultant vector which is very important to understand and how it is achieved by the addition of the vectors. Now, this is of clinical relevance in various clinical settings. For example, in the cross-cylinder examination, the toric aisle calculations, the misalignment of toric aisles, and the SI calculations. Now, the vector addition usually is in 180-degree dimensions, mathematically, if we consult all the textbook. However, in the ocular astigmatism, the vector calculations are based on 360-degree dimensions. This is the basic difference with vector addition that you see in the textbook, in the normal school textbooks. So hence the axis is doubled before the resultant vector is calculated. And the axis is then halved for the final resultant vector axis. However, for the basic purpose of understanding the vector addition analysis, the following explanation is based on the 180-degree dimension analysis only, just to simplify the understanding. Now, for vector addition, one of the most important prerequisites for the vector addition is that both the vectors are to be of the same signs. As can be seen, they have to be in the same direction or the same signs. Now, in this example, the vector A and the vector B, they are of the same magnitude. Now, if the two vectors are of the same magnitude, then the resultant vector basically bisects the angle between these two vectors. And it is, excuse me, sorry. So it whenever they're two, both the vectors are of the same magnitude, the resultant vector is exactly midway. It bisects the difference in the angle between them. Now, in this example, we can see that vector A is of a higher magnitude and vector B is of a lesser magnitude. In this case, the resultant vector would be closer to the vector with a higher magnitude. Higher the magnitude, more close will the resultant vector will be. Now, this will be, sorry, excuse me. Sorry. So the resultant vector will be closer to the vector with the higher magnitude. Now, this will be of clinical relevance in analyzing the axis rotation in case of cross cylinder, as you will see in the a few slides next. So, higher the magnitude of the vector or astigmatism, the higher will be the resultant more towards that. The rotation or change will be much less. Now, regarding cross cylinder, now Edward Jackson in 1987 described the use of fixed power Stokes lens called the cross cylinders to determine the power of cylindrical lenses required to correct the ocular astigmatism. Now, 2 decades later, that is 2007, May Jackson discovered that the cross cylinders could also be used to refine the axis of the astigmatic correction. The cross cylinders derives its name from the fact that it's a combination of two equal and opposite astigmatic lenses placed perpendicularly. The two most commonly used in practice, routine practice, are plus 0.25 at 90 combined with minus 0.25 at 180, or plus 0.5 diopter at 90 combined with zero point 0.5 diopter at 180. Now, this sign is basically used for the word combination. This 0.25 diopter plus is combined with minus 25 diopter at these two axes. Now, the above cylindrical combination can be written as philo-cylindrical, sorry. The above cylindrical combination can be written as spherocylindrical combination also. Here we can take either 0.25 diopter plus 0.25 as sphere, and the rest will be changed into the cylindrical power of minus 0.25, minus 0.5, or the minus 0.25 sphere can be taken and the rest will be taken as a cylinder. Here we can see that the cylinder is double and of different sign compared to the sphere. In either now in the 0.5 diopter sphere, cylinder cross cylinder can be written as either plus 0.5 diopter sphere and minus 1 diopter cylinder at 180, or minus diopter sphere with plus 1 diopter cylinder at 90 degrees. Now, cross cylinders are named by the power of the cylinder, and this is marked on the handle as can be seen here. So the above mentioned cross cylinders are of two powers, 0.5 diopters and 1 diopter respectively, and not 0.25 and 0.5. It is referred to as by these two total dioptric cylindrical power seen in the cross cylinder. The sphere in the lens is double and of the opposite side of the cylinder. The most important aspect of this cross cylinder is that the spherical equivalent of all the cross cylinder lenses is zero. Its principal axis is marked with the red and black, or the red and the white line. As in this scheme, it can be seen as the red and the black. The red is basically used for the minus lenses axis, and the black is for the plus axis. Now, this has basically this handle which can be twirled, and this is called flipping. It can be twirled, and the moment it is twirled, the direction of this axis will change. So the orientation is such that the handle of the GCC bisects the principal axis by 45 degrees. And this enables twirling, and the orientation position of the minus and the plus and the axis can be interchanged rapidly and alternatively. Now, in this image, one can see the primary orientation of GCC. The handle is down to the right and is 45 degrees to the horizontal. The center 0.5 is written in such an orientation that it can be read very easily. It is written vertically like this. And the red marking, as I have already said, it's the minus cylindrical axis, and the black markings are the plus cylindrical axis. Now, as the spherical equivalent of the lens is zero, placing it in front of the patient's eye does not change the position of the coronal room. It can, however, reduce or increase the astigmatic error. This is one of the most important aspects of this cross cylinder, that the spherical equivalent is zero, so it does not affect the coronal room or the circle of least diffusion or confusion. Now, what are the indications of Jackson's cross cylinder? The indication of the using Jackson cross cylinder is to refine the astigmatic axis, or to refine the astigmatic power, or to detect the astigmatic axis and power in the absence of retinoscopy when we do not have the details of astigmatism available, or in case the patient is not showing any astigmatism. Now, refining the axis. Now, this is basically based on the vector addition, as I already stated before, as you will see now. The cylindrical axis is refined first and then cylindrical power. Now, this aspect is also very important. The axis has to be refined because the correct axis can be found in the presence of incorrect power. But the full cylindrical power will not be found in the presence of incorrect axis. So before using GCC, one must ensure that the center of the least confusion is on the retina. So we have to give the spherical correction so that the circle of least confusion or diffusion is on the retina or the internal limiting membrane. The cross cylinder is placed over the trial lens in such a manner that the axis of the cross cylinder straddles the trial lens axis. For example, if the trial lens has a cylinder axis at 180 degrees, hold the cross cylinder lens before the eye with this handle in line with the axis of the trial cylinder, so that the axis is at 45 degrees while the other axis is at 135 degrees. The cross cylinder is then rotated 180 degrees And this is done by twirling the handle or flipping the axis so that the meridian that was originally at 45 is now at 135 degrees and vice versa. Now this is the case. You can see there's -1 cylinder at 180 degrees. Now the handle of the cross cylinder is basically in line with this axis, so that this axis is straddled by two axes, plus here and minus here of zero point 0.5 diopters. The total dioptric power that is of this cylinder is basically -1 at 45. So what you will see one axis is here is at 180, and the minus this of total power is -1. This will be at the 45. So this is triangling this axis. This is triangling these two. This is at 180. So the net resultant, as I told you, now we have -1 here, we have -1 here, here, and -1 here. So this is 45. So if you bisect that angle, it will be 22.5 degrees. Here the vector addition or analysis comes into play. Now this is just a rough estimate. I'm not giving the mathematical. I purposely have avoided all the mathematical calculation just to make the explanation much easier for everybody to understand, although I am aware of all the mathematical calculations. So you can see that it is midway between 45. So this is 180 axis, and this is another, let's 45-degree axis. So this will be bisected, and the resultant axis will be somewhere between 22.5. So this is the vector that I have shown you as I've explained. So one axis is at 180, and this is another one. So since both magnitude is same, the resultant will be exactly midway. Now, what we do is we twirl or flip the axis. Now, this will be now reversed. This will be now 140 at 180 and 135. In this case, the resultant will be 157.5, as can be seen here. One is 180, one is 1. Since both the magnitude are same, the resultant vector would be exactly bisecting the angle between these two vectors of the same magnitude. So here lies the importance of knowing or understanding. Now, other ways to mark it up. I think it'll be the best to understand the basics. Once you understand the basic concept of a schematism, okay, where both the axes, both the vectors of the same direction, same signages, so the resultant is very easy to know. Now, if the patient reports equally blurred vision, now let's see, analyze what will be the result of putting these lenses, the GCC, along with the trial correcting lens. Now, if the patient reports equally blurred vision in each of the position of the cross center, means the trial lens axis is correct and no change of the axis is required. If, however, the patient reports better vision in one position, the trial lens is rotated. So when using a plus cylinder, as you have seen, the trial lens axis moved toward the cross cylinder plus axis because the whole resultant axis has moved toward the plus one. Now, similarly, in the minus cylinder, the trial lens axis, the trial lens is moved toward the cross cylinder minus axis. By the same analogy of the vector addition, both the vectors has to be of the same sign. It cannot be 1 plus and 1 minus, because subtraction is not done. Subtraction is done in a different form. So ultimately we have to add both the vectors. Both have to be same sign, either minus or plus. Now next, the cross cylinder is repositioned again to straddle the trial lens axis. Once the correction has been made, now the whole procedure is repeated again. Again, it is repositioned so that it straddles the trial lens axis, and then again the procedure repeated until the patient reports equally blurred vision in both the position of the cross cylinder. So till then we have to keep on repeating and keep on changing the axis. So this is how we arrive at the refining the axis. Now, fundamental to all this is that the spherical correction with the circle of least diffusion should always be on the retina. Otherwise, this will not give the correct answer. Now, next comes refining the cylindrical power. Now, again, the basic concept one has to understand. Now, assume in this case, there's a one diopter astigmatism. But this, after correcting the spherical error so that it is the circle of least diffusion is on the retina, as can be seen here, 0.5 diopter will be integrated to this circle of least diffusion, and 0.5 diopter will be beyond that at f2. Now, so hence appropriate space placed before the patient's eyes, so the position of the circle of diffusion is on the retina. This is one of the basic requirement and the starting point for the refining of the cross cylinders for the cylindrical power. So as you can see, the total combination will be basically one diopter. So it is distributed all the stigmatism, the total cylindrical part is distributed half anteriorly and half posteriorly. Now in this case, now suppose we have plus 1 diopters at 180 degrees is placed. Now it and is aligned. Now what we do, we take a cylinder where the axis here, in this case, the axis of the cylinder is aligned with the axis of the trial correcting lens. In the axis, we used to put the handle in the same axis, but here the axis is basically aligned with the axis of the correcting cylinder axis. So in this case, once we put like this, the 0.25 diopter axis is in the same direction as the correcting cylindrical axis in the trial frame. So there will be addition of 0.2 on both the sides of the retina. So the net astigmatism will become 1.5 into 180, as can be seen here. So zero point 0.5 will be added anteriorly and zero point 0.5 will be added posteriorly. So net astigmatism or cylindrical change will be now 1.5 diopter. So as can be seen here, each focal line will move 0.5 diopter away from the circle of least division, and the total astigmatism will now measure 1.5 diopters. And the circle of diffusion or confusion enlarges. So in this case, since the circle of confusion this diffusion is enlarged, the patient will report an increased blur. Now we flip the axis. Again, we put the handle and we flip the axis. Now this time is the other way around. The minus axis cylinder is in line with the plus axis cylinder in the trial lens. So this way, there'll be a reduction of 0.25 on both the sides of the retina. So there'll be now reduction of, because of that, there'll be a 0.25 moving towards the retina, both anteriorly and posteriorly. So stigmatic error now measures only 0.5 diopters. Now, since the stigmatic error measures only 0.5 diopter, the circle of least diffusion or confusion is now much smaller. And this will help basically in patient telling the patient, that patient will say that he has now improved vision. Now this is again because of the small circle of diffusion. Sorry. Now there'll be a point when it'll come, and on correcting, we have to keep on repeating this thing on adjusting cylinder till the patient reports that now he can see it as a point, and the circle of diffusion now is reduced to a point image on retina. Or at this point, if we add any cylinder in any axis, whether this is flipping or not flipping, there'll be no change in the perception of the patient. Now, placement of the cross cylinder in such a situation when it has become all the ametropic correction has been made, both the spherical cynical lenses have been put in the trial frame. Now, placement of cross cylinder in front of the eye, it only produces astigmatism. Both ways, flipping or otherwise, it will produce the same level of magnitude of astigmatism. So, no matter which way the cross cylinder is aligned, the patient will say that's equal blur on both the two types, whether you put it as a plus horizontally or the minus horizontally. Now, this is the endpoint of refraction, and the patient vision is properly corrected, and we can say safely that this is the final cylindrical power to be prescribed to the lens, to the patient. Now, was one of the very important aspect is, once you change the cylinder, there's a need for corresponding change in the spherical power also, because we have to keep the spherical equivalent as 0. Now, otherwise, for example, in this case, I'll just give an example. Now, we have minus 1 diopter spherical and minus 0.75 diopter cylindrical license. Now, if this change of 0.5 diopter cylindrical power, the spherical power change would be 0.25. Now, the spherical equivalent of this combination is 0. So, it's very important that if you change the cylindrical power, the corresponding change in the sphere has to be done so that the spherical equivalent power remains 0. So, the final part in this case would be 0.75 diopter spherical, because we have to add 0.25 to this will become 0.75, and we have to then add this to this, they will become 1.25 diopter cylindrical. Now, clinically, it is known that large axis steps should be used for refining the axis of a low pass cylinder, but small steps are required for refining the axis of a high pass cylinder. Example, 15 degree of axis rotation for a 0.5 diopter cylinder is equivalent to 5 degree of axis rotation for a 1 diopter cylinder, or a 2 degree of axis rotation for a 3 diopter cylinder, or 1 degree axis rotation for the 5 degree cylinder. So cylindrical power is usually done by using steps size of 0.5 diopter. So it's important that if the magnitude of the cylinder is less, so you can afford to have a bigger rotation because the patient will otherwise will not perceive the change. But if the cylinder magnitude is high, even a small change in the rotation will cause a significant change in the visual perception of the patient. So now third option comes how to detect astigmatic axis and power in the absence of retinoscopy. We have only spherical power where the patient has approximately said that he is improved or not improved. So we want to see if there is any astigmatism in the patient or not. So when there is no prior astigmatic correction available to the eye, the Jackson cross center is presented at first with axis along 180 and then at 90 degrees. Now if the patient prefers a flipped position, add a cylinder parallel to the prospective axis chosen. So once it is done at 180/90, the patient will say some preference. If there's a change, one can always put it. But if the axial cross center are initially placed, now there's a drawback in this method that if the axis of the cross center are initially placed at 45 degrees away from the axis of the ocular astigmatism, the resultant vectors will be equal. In such a case, the cross center will completely fail to detect the astigmatism because the resultant blur will be equal for the two flip choices. Even large amounts of ocular astigmatism will be missed by the cross center test under these circumstances. So to avoid this problem, the cross center test must always be applied in a second orientation before it is concluded that no significant astigmatism is present. Hence, if no flip choices or preferences found when testing at 90 and 180, testing at 45 and 135 will then provide the best chance of detecting any ocular astigmatism if present. Now, ideally, the best monocular visual acuity is obtained when the circle of least division or condition is collapsed to a single point in a sharp focus on the retina. However, a change in center power or axis of an adult's prescription may cause enough alteration of the binocular spatial sense that the optimal lens for the best acuity may not be tolerated under binocular condition. So for this reason, it is sometimes appropriate to rotate the axis of the correcting center away from the correct axis towards the old axis. Patient may not accept the new axis, which may be the correct axis. So it's very important to understand this. Rotating the axis of the correcting center will induce a residual astigmatic error that will be perceived by the patient as a blur. Now, to minimize the residual astigmatism, trigonometric analysis can be used to demonstrate that the correcting center power should be reduced from its full power to c cos 2 theta. I don't want to go into deal of the mathematical calculation, but in short, you have to understand that if the axis that the patient is accepting is not the true correct axis, you have to reduce the power so the residual astigmatism is reduced. Now, let's come for the clinical relevance of the cross centers. It may be also used apart from what I've described the various methods and usage of the cross center for prescribing glasses with the reduced clinical power, for glasses prescription as a cross cylinder, and for the toric power in the intraocular implants. In clinical practice, the ophthalmologist may wish to prescribe glasses with less than full cylindrical correction. Now, this is especially true in adults receiving glasses for the first time. To reduce or cut a cylinder, a cross cylinder is decreased to a certain amount and the sphere increased by half that amount. Thus, the spherical equivalent remains unchanged. Example, the patient prescription is -4 cylinder, -4 sphere, and +4 cylinder. Now, ophthalmologist wishes to cut the cylinder in half. That is, he wants to give only +2 diopter of cylinder. Reduce the cylinder by, let's say, 2 diopter. We'll have to reduce the cylinder by 2 diopter. Now, this is the reduction that we need to do. So, the corresponding change in the sphere would be half of this and of opposite sign, that is +1 diopters. The final prescription would be -3. This will be added to +4. Sorry. So this will be added to -4. It will become +3 diopter sphere, and the remaining will be +2 diopter at 90 degree. The spherical equivalent of the initial and the final prescription remains the same, -2 diopter. We can counter the spherical equivalent of this combination. Initial prescription will be -2, as well as the new prescription of this also will be the same. So the patient will be much more comfortable initially for some time till we decide to give the proper full correction. Now, in some cases, glass prescription as a cross cylinders can be given. In some cases, a cross cylinder is preferable to a sphericylindrical. because it is lighter and provides a wider field. Example, plus 3 diopter sphere and minus 4 diopter center at 180 degree can be written in the cyclical form as plus 3 diopter center at 90 in a combination with minus diopter center at 180. This basically helps in decreasing the weight of the lens because of the both the powers are pretty high powers. Now the last is the toric power as a cross cylinder. All standard IL formulae calculations are based on the average of the K1 and K2. The refractive outcome is based on the spherical equivalent and not the residual sphere, as some of the, especially the residents, they believe. Now, however, in toric ILs, the target is to correct the pre-existing corner astigmatism. Hence, the average of the K1 and K2 may lead to calculation errors. Normally the biometry is calculated in the form it takes the average of K1 and K2. Thus, the toric power is incorporated as cross cylindrical power. Now, since the spherical equivalent of the cross cylinder power is 0, the formula needs no correction and would be still valid. However, the final toric power calculation adjusts by reducing the corresponding spherical power. So, it's important, especially in this, whenever we do the biometry, there is option K, what do you intend? And it says the sphere 0. The 0 does not mean 0 sphere, it means 0 spherical equivalent. So that can be a whole set of endless possibilities. So in short, these are my references, and I can only say that astigmatism affects the quality of life. As a result, the uncorrected astigmatism also affects the quality of life. Hence, it is of clinical relevance and of practical significance to manage astigmatism for optimal refractive outcome. Thank you.
Thank you. Thank you so much, sir, for an extensive talk. I would like to introduce, before we go further, I would just like to introduce our expert panel. They have taken the time to come all the way and give their expert opinion. We have Dr. Nepalia, sir, from St. Francis Hospital, Ajmer. We have Dr. Krishna Prasad R from MM Joshi Eye Hospital, Hubli. We have Dr. Kulkarni ma'am from Yanapoya University, Mangalore. And we have Dr. Vijay Raghavan, sir, all the way from Coimbatore, Arsan Eye Hospital. And may I request sir to unshare the screen, sir? To Paruki, sir.
Fine.
Thank you, sir. Now, can I request Vijay Raghavan, sir, to please give his opinion on the topic that Faruqi, sir, very beautifully covered. And cross-cylinder definitely is a difficult topic, and I have experienced it too.
Fariki sir, you have done a fantastic job and you have
Thank you, sir.
covered everything. Everything, of course, highly, some of the things particularly useful for the postgraduate students. And this thing, normally we ask questions how the cross cylinder is made. Suppose some 0.5 cross cylinder. Always they have to tell what one sphere is there, double the value of the cylinder opposite side. That's all. And which one will you do first? Axis or power calculations? They have to answer axis to be corrected first. Then only they can do power corrections. For axis, they must do a 0.5 cross cylinder. And for power, they will get 0.25 cross cylinder. These are some of the basic questions we ask. And of course, you have told that is to correct the axis, the handle should be parallel to the axis of the cylinder that is in trial set or trial frame. That's the most important thing. So that 45 degree this side is minus and 45 degree this side is plus and all. And one more thing, sometimes they get confused. Suppose that it's not written as plus 0.5 or something like that, the first cylinder, and they will be confused. You have rightly told, sir, that is red color, always a minus, and the black color is always a plus. That's all the power. They should know that. This is what normally we expect from the students, and the common exam questions also. And you have told rightly about the basic, that is a spherical equivalent also you have told. Is also a common question we ask in the exams for the students. Spherical equivalent of cylinders is also common. And Sturm's conoid, it is really nice. And the Sturm's conoid, they have to practice. My advice to the students, postgraduate, they have to practice how to draw the Sturm's conoid for the prescription. Suppose they are getting the prescription of something, they have to show in the Sturm's conoid where is the retina and all. They have to show, depends upon the diagnosis. And one more thing, normally we ask one more question. Suppose if you want astigmatism, for fun use all of this. If you want astigmatism, what type of astigmatism do you want? Well, always they should tell mixed astigmatisms here, because the circle of least confusion that is in the mixed area. That's why always better to have a mixed astigmatism, so that a round object will be seen as a round. Instead, other things will become a line or a oval and all these things. That's why the confusion. So basically the student should tell always I prefer a mixed astigmatism for the benefit of the patient. Thank you very much. Very nice, sir. Thank you, sir. I've
Thank you,
learned a
sir.
lot from you. That's the most important thing.
Thank you, sir.
Thank
Thank
you
you
very
so
much,
much,
sir.
sir. Thank you, sir.
Thank you, sir. Thank you so much for giving your input, sir. And may I request Dr. Uma, ma'am, to just tell the three pointers which I think the postgraduate should keep in mind while answering. Like, Dr. Faruqi, sir, has absolutely explained things in details. And what would be the 3 pointers that you would expect the students to tell you when you are asked taking an examination?
The use of cross cylinders, JCC. The first point that any PG or any fellow should know is how to refine the axis and how to refine the power of the axis. And the second thing is about the role of the use of JCC in giving high prescriptions, high cylindrical prescriptions for the first time. So many times we get patients who have a very high astigmatism, and the high cylinders have to be given, and we are worried that they may not be able to tolerate such high cylindrical powers at the first time. And so sir has beautifully described how you can reduce the power at the first instance, making sure that the spherical equivalent remains same, and then slowly, gradually go on increasing the cylindrical power. I think that is the second point take home from Faruqi sir's presentation. And third is, I think the use of cross cylinders in the form of spectacles and in the form of toric lenses, wherein the weight of the lenses comes down and they are lightweight compared to the cylindrical combination, is a third take-home message I feel. Yeah, that's it for me, from my side. Yeah.
Thank you so much, ma'am. Thank you. And thank you, Faruqi sir, for covering this important topic. And thank you, sir. And we will now move on to our second speaker, Dr. Kavita V. ma'am, and she'll be talking on understanding cycloplegics. I
Thank you.
must appreciate the efforts of the AIOS team. I mean, Dr. Partha Viswasa, President, and Dr. Santosh Vanavas, Secretary, and Dr. Manoj Mathur, Treasurer, for putting this together. I think it's a very important initiative to put these topics together for the postgraduates. So, over to you, Kavita, ma'am.
Is my slide visible?
Yes, ma'am. You can put it on slideshow, ma'am.
Yeah. Just want to minimize the video part. Yeah.
It's not proceeding, ma'am.
Yeah, it's not moving.
Ma'am, you can go back, closing it once again. Yeah, now it's fine, ma'am.
Oh, okay. It's seen, right? Yeah. So I'll be talking on understanding cycloplegics. At the outset, I'd like to thank AOS for giving me this opportunity. I have no financial interest in this presentation. Now, what does the word cycloplegic mean? It is an adjective that means description of the meaning, or it's inducing paralysis of what? Of ciliary muscle within the eye, as a result of which there is loss of accommodation, that is the ability to focus or to see an object which is near, or at the same time, see at a distant object. Now we know that when the light rays fall on the retina, that's the afferent pathway, it takes on to the visual pathway, and what we perceive is actually the function of the primary visual cortex. Now, looking at the efferent pathway, the parasympathetic fibers arise from the Edinger-Westphal nucleus. That is the third oculomotor cranial nerve nuclei, oculomotor nuclei, and passes on to the ciliary ganglion, where it relays and from there arises the short ciliary nerves, and it carries the parasympathetic fibers and then supplies the sphincter pupillae and the ciliary muscle. Now the sphincter pupillae, what does it do? It constricts the pupil. And the ciliary muscle, yes, we need it for the process of accommodation in terms of its action on the zonules and thereby the curvature of the lens surface, which actually helps in accommodation. So this is what you can see actually. Here you see the ciliary muscle is relaxed. So when the muscle is relaxed, the zonules are under tension and the whole lens anterior posterior width or the length becomes lesser, or or you can say it as flatter, and therefore you will be able to see something at distance. Now what happens in accommodation is the ciliary muscle contracts and the zonules become loose, as a result of which the anterior posterior or the curvature of the lens increases, thereby trying to focus an object which is closer. So the whole process, this whole process on the right side is known as accommodation. Now what is responsible for accommodation? So this parasympathetic, the chemical mediator for parasympathetic system is the acetylcholine, and when this acetylcholine acts on these muscarinic receptors, there are 5 types of muscarinic receptors in our body. The most common type is the M3, which is present in the sphincter pupillae as well as the ciliary muscle. This is the site of action of acetylcholine, where it brings about contraction of these two muscles, bringing about pupillary dilatation as well as ciliary muscle contraction, helps in relaxation of the zonules and accommodation. Now these cycloplegics, they are cholinergic antagonists. So you have a substance which counteracts this effect. So what is it called? It is known as competitive inhibition at the muscarinic receptors, which induces pupillary dilatation and bringing about passive mydriasis. Why we are calling this as passive mydriasis is because this is a constrictor pupillae. So we are abolishing constriction, therefore there is dilatation. There's a reverse action. It is not acting directly on the dilator pupillae. So this is known as passive mydriasis, and the second action is the paralysis of the ciliary muscle, therefore loss of accommodation, which in other words is cycloplegia. And the agent or the drug which brings about this action is known as cycloplegic. On the other hand, we have another drug which is the adrenergic receptor agonist, leads to pupillary dilatation, and this is an active process, and this has no cycloplegic effect, that is the drug phenylephrine. Few cycloplegics which also have the mydriatic, most of these drugs have mydriatic effect as well, and the drugs that we commonly use are atropine, homatropine, cyclopentolate, tropicamide, and scopolamine. Of course, it's not so commonly used in India. On the other hand, we have the adrenergic agent which helps in dilatation is the phenylephrine. What should we know about a drug when we are studying or understanding a drug? The classification of a drug in which this particular drug comes under, the chemical composition or the classification, and pharmacokinetics, how it behaves and how the body behaves because of the drug, the dose in which it should be supplied or applied, route of administration, indications, side effects, and contraindications. These are the headings under which I will be talking about these common drugs that we're using every day. Literally every day we are using these drugs, and without these drugs we cannot understand anything in ophthalmology. So the first drug is the atropine, especially in children. Pediatric refraction is a very, very crucial and critical arena in ophthalmology. So first is atropine. It is a natural anticholinergic drug, and the concentration of it is 1%. And the dose is, we have to remember that it is used 3 times in a day for 3 days in both the eyes. Action, as I said, it brings about passive mydriasis and cycloplegia. Uses, what are the indications? We have to categorize into two categories, that is for diagnostic purpose as well as for therapeutic reasons. Diagnostic, we know that we need to do refraction in children or in older children where we are wanting to understand the exact refractive status of that particular eye in that particular patient. And with the various gadgets that we are using nowadays, it is very difficult to understand the refractive status of the eyes. So it is best, when in doubt, best to use a stronger cycloplegic agent and understand the refraction. And coming to therapeutic uses, it is used for in cases with uveitis. Reason could be plenty. Post-operative, as simple as post-operative or post-cataract surgery uveitis, or uveitis itself, iridocyclitis due to many systemic conditions. And second is corneal ulcer. To relieve the spasm, we need to use atropine or its analogs. Chemical burns, post-cataract surgery, which I mentioned, scleritis associated with uveitis, amblyopia therapy, which we call it as penalization, so that it causes the blurred vision in the normal eye, so that the patient or the child can use the amblyopic eye. The normal eye will be made to become blurred. So this is an option for penalization, is an option when the child is not compliant for occlusion therapy, the conventional occlusion therapy. Now we have the low dose myopia, low dose atropine, that is 0.01% and 0.05% recently available for to be used in to prevent myopia progression. Now, looking at the side effects, we have to categorize into two headings. One is the ocular side effects, and the other one is systemic side effects. Let's look at the ocular side effects. The most common, because of pupillary dilatation, there is photophobia and allergic dermatitis because of the drug. So, allergic dermatitis, the patient can have redness, itching, instant lid edema, preventing further use of this particular drug. If it is used for a longer period of time, the patient can develop dry eyes. This is usually secondary to the preservative that is present in the drug. Risk of angle closure glaucoma is definitely there, because once if there is a narrow angle and the pupil dilates, there is peripheral crowding of the iris tissue, so bringing about an attack, raised IOP and attack. Now, what are the systemic side effects of atropine? Because it is parasympathetic activity is abolished, there is chances of urinary retention, and it affects the GI motility, and it slows down the GI motility, bringing about constipation, and there is restlessness, ataxia, and convulsions. So all these side effects we have to keep in mind when we are using any of the cycloplegics. Contraindications. Therefore, now since we know the side effects, we should be understanding, or we be able to derive at what are the situations or conditions where we should not be using this drug. So, hypersensitive to the alkaloids, angle closure glaucoma, congestive heart failure, patients with asthma or chronic obstructive airways, myasthenia gravis, pregnancy, and Down syndrome. So these are the contraindications. We should have it in mind before we use these drugs. In toto, you can remember this mnemonic to understand what are the side effects of atropine, which we have learned in pharmacology way back in MBBS. Mad as Hatter, which I said there can be restlessness and the altered sensorium, as we call it as. So it is mad as hatter. Blind as bat, because pupil is dilated and therefore we have decreased vision. So it is referring to the bat. Red as beet, because of vasodilation, and flushed skin. Hot as hair because all secretions are decreasing, and therefore the skin becomes very dry. All secretions in the body decreases. Dry as bone because the mucous membrane also becomes dry. So this mnemonic we can remember. Now coming to the next sister drug is the homatropin, which is a semi-synthetic anticholinergic drug. The concentration of this drug is 2%. Dose is 1 drop every 10 minutes, 3 to 4 times, or depending on the cycloplegic effect. If it's obtained or not, you can add additionally. Alternatively, this drug can be given for home application like atropine. We can give it to the parents to use it in the child for 2 to 3 days for 3 times in both eyes, like atropine ointment or atropine eye drops, and the child can be brought back for refraction after 3 days. However, the difference between atropine and homatropine is this, that homatropine does not dilate much. The maximum pupillary size will be around 4 to 5 millimeter. Beyond that, it doesn't dilate much. In a way, it is advantageous, especially when you do not want a fully dilated pupil, but also the cycloplegic effect is required. Then this is the drug of choice. On the other hand, atropine, you have full dilatation. Even cyclopentolate dilates very well. Tropicamide, other drugs which I'll be talking next, will also be dilating very well. Uses, as I mentioned, the same uses as that of atropine. And uveitis, some people prefer to use this so that they don't want full dilatation and photophobia. At the same time, they want cycloplegic effect, and it sort of keeps the pupil mobile, not fully dilated. Side effects are similar to atropine, but the frequency is much lesser than atropine. Contraindications are same, hypersensitivity and occludable angles, and we have to keep in, because it's similar to atropine chemically, we have to keep in all the side effects of atropine. Coming to another drug which is commonly used and easily available, and it's easier to use, is cyclopentolate hydrochloride. It is a synthetic anticholinergic drug, the concentration being 1%, and dose is 2 to 3 times 5 minutes apart. In between, we can add tropicamide plus to add on to the mydriatic effect. So it gives a strong cycloplegic effect, and mydrias is also very good. And it is used in refraction, especially in children. But the point is, the refraction in children with the squint, the best drug would be atropine and homatropine. Cyclopentolate may be in older children, but I prefer in all children who have squint, that is esotropia, to go with atropine. Cyclopentolate, sometimes those who are not willing for atropine, the side effects and the duration of cycloplegic effect lasting for 2 to 3 weeks, which I'll be talking later, I would prefer to use cyclopentolate. Cycloplegic effect is good enough in older children, and refraction values are also comparable with the atropine or homatropine. The other uses is once again anterior uveitis. If the patient is sensitive to atropine, and here only thing is that we need to use little more frequently, maybe 3 times a day. In uveitis, maybe it's required 3 to 4 times. Side effects is one I sometimes feel that these side effects are more scary for me compared to atropine. Atropine, we know it, but cyclopentolate, when we are using it, the one common, not very common, but scary side effect is the speech and speech disturbances that they have, and mental altered sensorium that the patient can develop after use of cyclopentolate. They behave very abnormally, and they are totally disoriented, which scares the parents as well as the doctor. So in this situation is one thing we need to calm down the patient, take them to a silent room and counsel the parents, counsel the patient as well. Patient will not be in any state to understand. Only thing we have to isolate them, and a lot of counseling is required, and probably we might have to sedate the patient. So then this whole scenario comes down. Their abnormal behavior is really scary, irrelevant, and it is not at all acceptable. Once you have faced this situation, I think you will never forget. And ocular side effects, like any other drug, it is known for its irritation, lacrimation secondarily, conjunctival hyperemia, and blepharoconjunctivitis. Contraindications are similar to atropine and homatropine. Any hypersensitivity reaction previously known, or when we come to know about it, better to avoid this drug. Angle closure glaucomas. In children with CNS disorder, history of seizures, developmental delay, I completely avoid this drug. Down syndrome, epilepsy, and cerebral palsy. All these conditions, I totally avoid this drug. Now, another important drug is tropicamide. It is also a synthetic anticholinergic drug. Concentration, there are two types, 0.5% and 1%. Dose is 2 to 3 times. This can be instilled 5 minutes apart, and you wait for 30 to 40 minutes and then look for the effect. And in older patients, maybe about 10 years, 12 years, it has a weak cycloplegic effect. So this can be used for refraction as well as fundus examination. Side effects is the stinging sensation. Contraindication is similar to the other drugs where there is hypersensitivity or angle closure. Gonioscopy is a narrow angle. Better to avoid these drugs. Phenylephrine is a synthetic sympathomimetic. It is a mydriatic adrenergic agonist. So the concentrations available are 2.5%, 5%, and 10%. Three times it can be instilled, 5 to 10 minutes apart. And main action is mydriasis, and useful for fundus examination, and also helps in the diagnosis of Horner's pupil to understand where the lesion is. Side effects is pain, lacrimation, keratitis, pigmented aqueous floaters, rebound meiosis, congestion. Systemic side effects, it can exacerbate hypertension, hospital headache, and tachycardia, arrhythmias, and blanching of skin. So any cardiac patients, we have to be very careful in using this drug, and hypertensive patients as well. Patients contraindicated definitely in patients taking MAO inhibitors, tricyclic antidepressants, methyl dopa, reserpine, etc. 10% phenylephrine should be used with caution in patients with cardiac disease, hypertension, aneurysms, and advanced arteriosclerosis. Any CVS problem, better to avoid this. Now, this combination is another frequently used drug, that is tropicamide with phenylephrine. We want additional mydriasis or faster mydriasis. We can think of this drug, but the concentration definitely varies. Tropicamide is 0.8% and phenylephrine is 5%. Scopolamine is a natural anticholinergic. The concentration is 0.25%. It's not frequently used in India. Side effects and contraindications are similar to atropine derivatives. Now, the other clinical conditions where we want some dilating drops, but we cannot use is one is preterm children or children with ROP, retinopathy of prematurity. We cannot use these drugs because they are relatively higher the concentration is much higher for these small kids. So what we have to do is we need to dilute these drops. T plus, that is tropicamide and phenylephrine drops. It comes as 5 ml bottle. Tropicamide is 0.8% and phenylephrine is 5%. So we need to dilute it. How do you dilute it? you remove 2.5 ml, some of them remove 3 ml, and then add 3 ml of distilled water. Then it gets diluted, and this can be stored for a week or so. Best is to, name it as diluted or ROP drops, anything it should have an indication. The bottle should have an indication that we have diluted. So, so that we are not doing a mistake of using the concentrated one or the one which we use in older children or adults. So this and the date of dilution should be mentioned over the bottle. The other way is use tropicamide, which is available as 0.5%, with phenylephrine, which is 2.5%. This is not available here. That also comes as a lower concentration, so that can be used. The other thing which I want to touch upon is the preservatives that are used in these cycloplegic drugs are benzalkonium, chlorbutalol, and phenyl mercuric nitrate. So why should we know about these preservatives? None of these drugs are preservative free. So definitely if you use it for a longer period, overdosing can have, these drugs definitely have side effects over the eyes. It can cause dry eyes and superficial punctate keratitis. So this is something we should be aware of. That's why I wanted to mention about the preservatives. Now looking at the onset and recovery of cycloplegics. See, atropine preferred in children less than 5 years. Home atropine may be little older children, 5 to 8 years. Now these are similar drugs. So peak mydriasis about 30 to 45 minutes it takes, and peak cycloplegic, it is longer duration for atropine. It takes about 180 minutes, so roughly about 3 days. You can take like that. Home atropine takes about 1.5 hours for its cycloplegic effect to come up and to have its maximum effect. And mydriasis recovery, that means the dilatation comes down. It starts constricting the pupil. So for atropine, it's about 7 to 10 days, whereas home atropine, it takes about 3 days to come back to its normal size, the pupil. Cycloplegic recovery takes about anywhere between 10 to 12 days for in atropine, 3 days again for home atropine. And when do you do retinoscopy? Usually on the third day. Home atropine you can do after 90 minutes as well. Sometimes I do it on the third day if I've given it for 3 days. I do it on the fourth day or the third day. PMT, when do we call for post-mydriatic or post-cycloplegic test, is after 3 weeks for atropine, after 3 days for home atropine. And the tonus allowance which we deduct is 1 diopter for atropine, and for home atropine it is 0.5 diopters. Coming to the most commonly used cycloplegic is the cyclopentolate hydrochloride. Children above 8 years, we can use this drug. As I mentioned, we should be aware of the complication or the side effect of this drug, which can occur in your OPD, and you should be cautious. As peak mydriasis takes about 45 minutes, anywhere 30 to 60 minutes. After 1 hour, you can do the retinoscopy. Peak cycloplegic effect is about 25 to 75 minutes. Within 1 day, mydriasis comes down, but cycloplegic effect takes about 2 days. Sometimes we have seen with various drugs, company drugs, same drug but with different companies, the cycloplegic effect has been there for 3 to 4 days also, and dilatation is also there. So better to call the patient after 5 days. It depends on the patient also. If they are hypochromic iris, dark pigmented, the effect lasts for longer time. So you check and then you call for, do the PMT. So cyclopentolate also is after 3 days only, I prefer. And the tonus allowance is 0.75 diopter that you need to deduct. Coming to tropicamide and tropicamide plus, it is used for mydriasis. However, tropicamide plus is having a weak cycloplegic effect. It can be used in older children. And the time taken for mydriasis and cycloplegic will be something like 45 minutes, and recovery period is about 4 to 6 hours for both mydriasis as well as cycloplegia. When do you do retinoscopy? Ideally after 45 minutes. And in case you want to call this, you have a doubt in the refraction, better to call for post-mydriatic test after a day or so. And the tonic allowances to be deducted is 0.25 diopter for this. Coming to phenylephrine is predominantly for mydriasis. You can get the effect within half an hour or so, and the recovery is 4 to 6 hours. And scopolamine is also for mydriasis, also has a weak cycloplegic effect, and it can, 3 to 7 days is the mydriasis and cycloplegic recovery. Anyway, we are not using this that frequently. So in toto, the strongest cycloplegic and longer acting is atropine, shorter is cyclopentalate, in between is homatropine. And you want pupil to be smaller, you go for a homatropine. You want only mydriasis for fundus examination, just switch to tropicamide or tropicamide plus. You want faster dilatation. And you want only dilatation, you can go for phenylephrine, keeping in mind all the side effects as well as contraindications. Now, one important clinical part that I want to tell is to avoid side effects. Most of these side effects, especially the systemic side effects, we can simply avoid it by the technique of punctal occlusion. After instilling the drops, ask your assistant to occlude the punctum for 1 minute. So this prevents systemic absorption. Any drug. I've started using this technique for even antibiotics, steroids. We don't know who are allergic to what and how they behave. Even steroids, because of nasal absorption and it going to the throat, they are complaining. Patients are complaining. So I even for steroids as well as antibiotics, I advise punctum occlusion. This is the consent form that we take in our OPD for all investigations. So it includes dilatation and refraction and any kind of allergic reaction that these patients develop. We are in a much prepared state. So what is the take-home message? I would say it is good to choose the right cycloplegic based on age and indication. Explain to the patient or parents or attenders about the possible side effects and then instill the drops. It's good to have knowledge of all the side effects of each drug specifically and to have it in mind. That's how you will be able to talk better to the parents or patients. Punctum occlusion to be advocated to avoid systemic absorption and systemic side effects. Of course, the local allergic reaction is something which we cannot avoid, but if first time we are using, we can tell them. And once any patient develops allergic reaction locally or ocular side effects, better to note it in our case sheet or EMR and also write it on a paper or in a diary of the patient or parents or attenders. Tell them that they are allergic to this particular drug and write it and put it in red, so the patient carries this book or paper with him or her to any other doctor who is in future that this patient needs examination. Patient should be able to tell the doctor that they are allergic to this particular drug. This would be a good habit to inculcate. Cross-check if cycloplegia is obtained before refraction. That is very, very essential. With the various lifestyle changes that is occurring nowadays, the exact refraction is to obtain the correct refraction is very difficult. So check for cycloplegia, whether it has occurred or not, simply by asking the patient to read a near vision chart. If they are able to read, that means there is the cycloplegic effect is not complete. So this particular testing can avoid confusion in the retinoscopy values. Explaining to parents to discard the drug after its use is very important. When we give atropine for 3 days, 3 times in both eyes to be applied at home, we forget about the fact that the patient is having the drug, ointment or drops. We forget about that. Once they come back, we tell that this effect will be there for 2-3 weeks and all those things that we will be able to tell. But we forget that the patient is having that. Accidentally, they may use that drop or ointment for something else, and it may be outdated. They may have side effects. Somebody else may have side effect, or some children playing with it may have any other problem. Especially if it is expired and they use it after 6 months or 1 year or so. All these possibilities are there. So it is important to discard the drug after its use. Thank you for this patient's listening.
Thank you so much, Dr. Kavita ma'am, for that extensive coverage on understanding cycloplegics. And to join our expert panel, we have Dr. Krishna Prasad sir as well. Thank you, sir, for joining us today and giving your time to us. So, if you have any comments regarding the last lecture on cycloplegics, and especially these topics are like very tricky because they don't come exactly in the clinical part, but it is always good to know about these things. And because of which, during the practical, we have so many questions on this, and we have a separate session on this as well. So, what do you expect from a postgraduate regarding these things?
Thank you, Farnas, and I think I'm very happy to be a part of this. I was doing a great job, GuruSangam, and definitely I'm very excited. Actually, it's a very important topic. Such a very nice compilation by Dr. Kavita V. Actually, my pupils are dilated because of excitement, I should say. Uh,
Thank you so
so,
much, sir. Actually, you had not come for the first talk. You should have been there.
no, I was watching actually. I could not get in. No, Farnaz had let me out of the thing. He had not sent me the link. I was only YouTube watcher for the first Dr. Fairozi's. Okay. Coming, I think very nice compilation, Dr. Kavita. I think you have almost hit all the points. One important thing is normally the subtraction or the you said the tone-noise allowance that we do for different cycloplegics. So whenever we are basically doing the correction from the objective refraction to subjective refraction. There is a very oversimplistic view that we subtract 1 for atropine, 0.5 for all the other things. Okay, but it's not really so. But especially in young children whose accommodation is very active, the amount of latent hypermetropia can be more than 1. We simplistically say that the latent hypermetropia, the amount of hypermetropia which is corrected by the normal tone of the ciliary muscle is usually 1. But it can be more than 1. It can be even 1.5, rarely 2 also. So sometimes the atropine can actually bring in more hypermetropia to the fore. So you have to keep that variation that it can be actually more than 1 also. But for all others, you can probably think 0.5 should be a reasonable estimate. But having said that, the subjective correction is the final thing because of this variation in the tonus allowance that each atropine or homatropine brings in. So we cannot prescribe any glass only on the objective method. So subjective becomes very important. And also, as she said, the action is variable. Even though the child has put in the atropine, when the child comes for a refraction after 3 days, the accommodation is still preserved in some children, even though they have put. So it is not only that so always it's better to check for cycloplegia before we assume that just because the parents are saying that I've put drops or ointment for 3 days, three times a day. So always check. Sometimes will be and very importantly, she said there's a lot of self-medication with the ointment that are available or drops available. They remain in the house and somebody puts it. I very vividly remember when I was a second year MBBS student, one of our own classmates put some atropine ointment, I don't know where he got it, just the day before our pharmacology theory test. We had the final exam of pharmacology and he had put atropine and he was blind as a bat, as you said. So we had to rush him to ophthalmology. Luckily, they gave him a +3 glasses so that he could, and we all read actually pharmacology for him. So I can understand that this can happen. So I always make it a point to tell them to throw it away or I take it from them when they come when the job is over. And one more point is there is sometimes in some of the practitioners some reservation to use atropine because of its long-acting nature of cycloplegia and mydriasis. But having said that, in a childhood esotropia, there cannot be half measures. You can't use homatropine and try to, completely uncover the entire hypermetropia because getting a perfect ocular balance or alignment is so important in an young patient. You can always put the parents or the child into that inconvenience of cycloplegia for 10 days. So no half measures with atropine when you deal with esotropia. And in severe uveitis where there's really a lot of synechiae formation, no mydriatic like atropine, nothing can really break the synechiae like atropine. So when you are having synechiae formation in process and in childhood cycloplegia, always resort to atropine. That's very important. And one more small thing is if somebody is having some kind of a congestion where they come in the OPD, no, normally when we dilate with phenylephrine, the congestion goes away. Or pre-operatively, many a time the person is actually having a conjunctivitis, a mild conjunctivitis. He comes to the surgery maybe in a camp or in a routine OT, and because they have put phenylephrine and tropicamide, the congestion goes away. We can actually miss a conjunctivitis in evolution. So I think this is something very important. So when you are in doubt, don't put phenylephrine because that can mask the hyperemia or congestion, which can be sometimes diagnostic. So I think she has compiled it very well. I think all the relevant points, what is required, not just for postgraduates, even for practitioners, has been very well detailed by Dr. Kavita. Hats off. Thank you very much.
Thank you, sir. Thank you.
Sir, can I add a point, sir? Yeah.
Yeah, please, sir.
Sir, see, she was fantastic. That is, Kavita madam told everything about the cycloplegic and all. But as an examiner, I used to ask one question. Why atropine is called as atropine? I used to ask. They have to tell atropa belladonna. It's an alkaloid from where it is derived.
And what is belladonna means? That is also important.
Next question, I used to ask, what is belladonna? It's a pretty lady. Whereas atropa, then I asked, what is atropa? Atropa means is one of the fates or goddess, killing goddess. It's a cutting this thread of life. Why, atropine 1% means actually 10 milligrams per ml. 1 ml has got about 16 to 20 drops. That 16 drops or 20 drops is enough to kill a child. By applying eye drops, getting absorbed, the child may die. That's the reason it's called atropa. That's why it's given a name called atropa belladonna. That's what I used to tell our students as well as my Viva question is. If they answer distinction, of course, I will not fail. That is okay. Thank you, sir.
Thank you, sir. Thank you so much.
Thank you so much. So let's move to the next talk. I invite Dr. Natasha Radhakrishnan. To deliver her lecture on subjective refraction.
Hello, good evening to all. Let me just share my slides. Sorry. Are my slides visible?
Your slides are visible, ma'am.
Okay. So today we are going to learn about subjective refraction. Subjective refraction is the term applied to the technique of comparing one lens against another using change in vision as the criterion to arrive at the dioptric lens combination that results in maximum visual acuity for a patient. Now, subjective it is called because it is dependent on the patient. This is not possible sometimes with uncooperative or retarded individuals and can be altered by malingering and in poor or slow responders. So the first thing you do when you're doing your subjective refraction is to introduce yourself. You do a quick history taking because occupation and visual needs are very important when you're prescribing glasses. The present glasses should be looked into, symptoms with the present glasses, previous treatment history, any systemic diseases and medications are also important. The first step is to determine pinhole visual acuity. Now, what is the start line? What do you start with in your trial frame? So you can start with retinoscopy values after cycloplegic refraction if you have that. You can start with a dry retinoscopy if you can do that. You can start with an autorefractometer reading or the present glass power if the patient is already using glasses. A rough guide based on visual acuity is a denominator divided by 18 in the Snellen visual acuity. For example, if the patient reads 636, approximately 2 diopter of refractive error the patient will have. Now, dry retinoscopy, the simple way of doing this is to place your distance correction, that is your plus 1.5 diopters or 1 diopter, depending on the length, distance at which you're holding the retinoscope. This fogs the eyes and prevents accommodation. Do your retinoscopy using a spherocylinder method over this. Remove the distance correction from the trial frame. And what do you have? You have something close to the patient's refraction in the trial frame. If your patient reads 612 or better with the lens in the trial frame after your dry retinoscopy, half the battle of your subjective refraction is won. Now, tips and tricks before we start. Systematic, so that all the steps are done and you are not missing any step. Minimize the error due to the subjective nature of subjective refraction by using checks. Do it at a fair speed so that you don't tire out your patient. Speak clearly what you expect from them and be very patient with your patients. Seat the patient at 6 meters from the Snellen chart. Place the trial frame ensuring centration and comfort. Believe me, there is nothing more difficult than a patient who doesn't like the trial frame poking into him. So you have to ensure comfort. Place the appropriate correction in the frame and either occlude or fog the other eye. First is to determine the best spherical refraction. You add plus first, power depending on the visual acuity. Suppose you have good visual acuity, you start with 0.25 and 0.5 if the visual acuity is less than 6/12. If better, proceed with 0.25 increments, always placing the next lens first before you remove the previous. If it is getting worse with plus, then you add a minus 0.25 and see if the visual acuity is better, and then proceed in 0.25 increments in the same direction. Stop when the visual acuity is 6.6. Do not add more minus if minus is what you have been adding to the refraction that is there in the trial frame. Now, if the patient says better, as you're adding more minus, if the patient says better, you must clearly ask if the letters are just getting smaller and darker, or if the visual acuity is actually better. So better from the patient should always mean an increase in visual acuity, because myopes have a tendency to accept more minus than they require. And you should consciously avoid this mistake. The aim is to determine the minimum minus correction or the maximum plus correction that gives best visual acuity. Next is to determine astigmatism. The cross cylinder is what we commonly use to examine astigmatism. You can quickly use the cross cylinder. You know that it is a combination of two cylinders of equal strength and opposite sign placed with their axis at right angles to each other, and the handle is placed at an angle of 45 degrees. You have in both 0.25 and 0.5 powers, and the red line corresponds to the minus cylinder and the white dot or line corresponds to the plus cylinder. And when you are doing with visual acuity better than 612, better to use a 0.25 diopter cross cylinder, and less than 612, use a 0.5 diopter cross cylinder. You can use it to determine if the patient has astigmatism by using it at 90 and flipping over to 180 and doing the same with 45 and 135. If you already know that the patient has a cylinder, then the next step is to refine the cylinder axis. So the first you have to refine the axis and then you have to refine the power. So with the best sphere in position, which we already looked into, ask the patient to look at one line above the best sphere acuity. This is because the cross cylinder will blur vision slightly, and to appreciate the difference between the two flips, it is better to use a line above the best corrected line with your spherical refraction. Now keep the cross cylinder with the handle coinciding with the cylinder axis in the trial frame. If it is a minus cylinder in the trial frame, you look at the red line of the cross cylinder. Determine which flip position is better, red line to the left or red line to the right of the present axis. If one position is better, you move the axis 10 degrees towards the preferred position. This is a small video that is showing the this is the small picture that is showing the cross-cylinder testing. You can see the axis in the trial frame and how the cross-cylinder is held. Now you keep repeating this till both flip positions are equally clear. Now, once the axis has been refined, next is to refine the power. For here, you have to keep the axis of the cylinder and the axis of the cross cylinder coinciding with each other. There you kept it at 90 degree, at 45 degree. Here you're going to keep it coinciding. In position 1, red lines coincide means you're increasing the minus cylinder value. And when the white dots coincide, you're decreasing the minus power. And again, you look at the flip positions and decide whether you want to go up in the minus direction or go down. This video shows a small...
Let's see the same sequence from the patient's view. Which is better now, 3 or 4? 3 or 4?
3.
3. Now, 5 or 6, or about the same? 5 or 6?
They're about the same.
Good.
So this is how you test a cross cylinder, and this is how the patient sees it. So you have to give clearly the choice. Don't keep moving the cross cylinder up and down, confusing the patient. You have to clearly say position 1 is this, and then flip it and show position 2 and make the patient give a choice. And if you use the same numbers again and again, there is a tendency for the patient to just keep saying 1 or 2. So that is why you must go to 3 and 4 when you have moved the cylinder and then you are testing it again. Now, whenever you're doing cross-cylinder testing, always remember to add sphere of half the power and opposite sign of the cylinder for every addition of 0.5 cylinder power. This is to move the circle of least diffusion onto the retina so that clarity is there and maximum clarity is there. And like I said, if always ask clearly which position is better. And if the patient keeps moving you back and forth, then you must change the order of the presentation. The astigmatic clock dial and the astigmatic fans are other methods by which you can use to refine your astigmatic power. Once the cylindrical power is determined, you have to go back and refine the sphere once more, giving 0.25 increments up and down to get the best visual acuity. Next, you have to test duochrome test to refine the sphere and ensure that the patient is not overcorrected, especially if your patient is a myope. This is based on chromatic aberration. The short wavelengths are focused in front and long wavelengths behind the eye in an emmetropic eye. This is what a duochrome looks like. It has black letters on red and green background. The technique is to fog the eye to 6/9 and ask which letters are clearer. If the red background letters are clearer, the eye is slightly myopic, and if the green is clearer, slightly hypermetropic. Now, you must always leave your patient either red clearer or both eyes equally, or both colors equally clear so that myopes are not overcorrected. Now, this you have done monocularly till now, and all these steps should be repeated in the other eye. So you have to refine the sphere first, refine the cylinder, and in the cylinder you will refine the axis, and then you will refine the power. Now you go back and refine the sphere once more, confirm that you have not overcorrected a myope with duochrome. And finally, you have to do what is called a binocular balancing. Unequal accommodation demand in the two eyes can result in eye strain because you're doing the testing monocularly. You can avoid this in old people with no accommodation and in pseudophakes, and it is needed only when the patient has really good visual acuity, like 6/9 or better, and in a very young patient. Borish method of doing this is to dissociate the two eyes with 3D prisms, base up in one eye and base down in the other. Now the patient sees two charts, one on top of the other. Now fog with plus to 612 and compare the two eyes. If not equally blurred, add plus in the clear eye till both are equally blurred. Now binocularly reduce the plus till visual acuity is 6/6. This is how cross-cylinder testing, the Borish method is done.
2 lines of letters, one above the other. The right eye sees the lower line. Both eyes are fogged, and the patient is asked if both lines of letters are equally blurred. If the patient reports the lower line to be clearer, more plus power is dialed in before the right eye until the lines are equally blurred. The 6-prism diopter prism is then removed. The smaller lines are shown binocularly, and sphere is changed binocularly in the minus direction until best vision is reached.
Another method of doing this is to fog both eyes with +2, place a minus 0.25 in front of one eye, and perform alternate occlusion and see if there is an appreciable difference in clarity. If the patient can identify the eye with the minus 0.25, the eyes are balanced. And if it is not in balance, you add or subtract the sphere till balance is achieved. And you repeat the same in the other eye. Now remember that sphere adjustment of binocular balancing is never to be more than 0.25 to 0.5. Otherwise, it will completely mess up your subjective refraction. The near add is the next thing to do in the presbyopic age group above 40 years in our country, based on the age and based on the amplitude of accommodation. A rough estimate for presbyopic add in tropical is about 45 years, will be around 1.5. This chart that is shown is in the temperate climate where presbyopia sets in much later. The Royal Air Force rule can be used to measure the exact amplitude of accommodation and the near point distance. It is a bar with a box with various targets on all 4 sides. The box can be slided over the bar, and the bar is marked one side in centimeter, inches, diopters, and corresponding age. And to determine the near point of accommodation, a sliding target with 6-9 letters is moved towards the eye until the closest point is found at which it can be seen clearly. The near point of accommodation is determined for each eye first and then for both eyes. Measured in centimeters, marked on the scale, measures the near point of accommodation. And like we said, in the other side, it's in diopters. A normal value at 20 years is 8 centimeters, and by about 50 years, it recedes to 46 centimeters. The amplitude of accommodation is by the Hofstetter formula. The minimum amplitude is 15 minus 0.25 into age. Let me not go into the details of that. Let us go into reading addition. Give reading addition depending on the visual needs of the patient, the work that the patient does, the hobbies of the patient. Adjust the IPD of the trial frame for near vision. This is a very important step because the centration of your distance vision is not the same as for your near vision. So you must bring the trial frame 2 millimeter closer before you start your near vision addition. Place the appropriate reading add over the full distance correction. Ask the patient to hold it at his normal reading distance and then see how much correction to give the patient. Now, after giving reading add, a tip is that if you ask the patient to read the N6 line, both at arm's length and closer, if he can still read it, then you can ensure that you have not overcorrected. You have to ensure that he has adequate reading distance range. Usually near addition can be done binocularly, but you can do it uniocularly when one eye is aphakic or pseudophakic. Last step is muscle balance. After you confirm the binocular visual acuity, do a cover test for tropias, use the Maddox rod in one eye and determine the presence of any phorias, measure the phoria using prisms. Finally, for refractive errors more than 5 diopters, measure the back vertex distance. It can be read off the side of the trial frames or you can use a scale. Now, what is the back vertex distance? It is the distance from the back of the lens in the trial frame to your cornea, front of the cornea. Why is this important? Because the effective power of a lens changes as the distance from the cornea changes. So if you have a minus power refraction, your effective lens power will be more when you move it closer to the cornea and less when you move it away from the cornea. So in some trial frames, it will be sitting in at a different distance. So if you have not measured this in high refractive errors, there is a possibility that the patient will be unhappy with the power that the spectacles that they get. So for any refractive error that is more than 5 diopters, measure the back vertex distance and mention it so that the dispensing optician can also understand at what distance you have actually measured the subjective refraction. Write this on the prescription. The methods by which you can measure perfectly are the vertexometer or a lens scorometer, but most of us use the scale at the side of the trial frame. So you have reached the finish point of your refraction. There are some special situations you cannot do just a subjective refraction in children and young adults. You must do a cycloplegic refraction first. In hyperopes, definitely do a cycloplegic refraction. In first refraction in myopes also, almost always you have to do a cycloplegic refraction because you will get confused with pseudomyopia. And in patients with intermittent blurring and asthenopic symptoms, it's better to do a cycloplegic refraction before you do just subjective refraction. In the presence of esotropia and hypermetropia, you give a full cycloplegic correction in which you reduce only the working distance. In the presence of intermittent exotropia, you can slightly overcorrect the myope to stimulate accommodative convergence. Children with non-refractive accommodative esotropia, you have to give bifocals to control the deviation, and this bifocal should be bisecting the pupil. Now, to summarize the steps of your subjective refraction, first refine the sphere, refine first cylinder axis, then power using the cross cylinder, refine the sphere once more, confirm with duochrome, do the same in the other eye, then you do binocular balancing. If the patient has very good visual acuity and is young, near ad, you have to check if the patient is in the presbyopic age group. Lastly, check muscle balance to look for phorias. Measure the back vertex distance if the power is above 5 diopters, and you will have a good subjective refraction. And some more tips: be familiar with your trial set so that you don't fumble and you locate what you want. Introduce and chat with the patient so they are relaxed and they are not stressed about the answers they have to give you. Give clear instructions and alert the patient when you're placing a new lens. Be systematic and follow this plan, and be confident and patient with your patients. And you will have a very happy set of patients at the end of your subjective refraction. Thank you all for your patient hearing. I'll be very happy to take questions if anybody has any.
Thank you so much, Dr. Natasha. That was indeed an extensive coverage again on subjective refraction. So the topic is open for the expert panel for discussion.
Very well covered, Dr. Natasha. I think you have been dabbling in pediatric retina, uveitis, and now you really like a pro. You handle subjective refraction, and it's very subjective actually. But for me, it really appeared very comprehensive. A few, just one of few 2 cents of mine from my side is, I think when we give near correction, the postgraduate should understand that the patient is in a he wants to impress the examiner or the doctor, so he will put all his accommodation at work and try to read it. So where we normally have to have some amount of accommodation always slightly relaxed or unused for a longer use of accommodation comfortably. So always I give the example of a weightlifter. Somebody who is a weightlifting champion will lift 150 kgs and win a gold medal. But the same weightlifter cannot lift 150 kgs throughout the day. It's a one-time effort, putting all his strength into action at one point of time. But he can probably lift 100 kgs quite comfortably for a longer period. So if I am endowed with only 4 diopters of accommodation, that is the amplitude of accommodation I have. If I put all 4, I can probably read N6. So normally when we make the patient read the near chart in the OPD, that is what happens. It is like 150 kgs at one point of time. He puts all his 4 diopters and reads N6. You think that he doesn't need any near correction. But outside, he cannot be using all 4 diopters throughout the day. He will start developing asthenopia and problems. So this is very, very important. So this is the whole problem. So whereas if he probably has to use only 3 diopters all the time and 1 diopter is for available for occasional use, then he will be very comfortable. I think this is the most important crux of the issue, because sometimes the patient end up buying a very expensive spectacle. Okay. It may be probably 30 times of your consultation fee, his spectacle cost. So there's a lot of accountability and responsibility on us when we probably prescribe a wrong spectacle because of these physiological factors. So the near correction normally they have. I normally give a small tip to the people who are doing my postgraduates or fellows is to move the reading material slightly forward and backward. For example, at a particular working distance, the patient is reading N6. If you move it 3 inches in front, and if the patient can't see it, then he is undercorrected. That means he has no accommodation left in him. He is putting all his accommodation at use. So he will be very uncomfortable for any distance closer than the working distance. Okay, that means we need to probably up his plus number. Maybe another 0.5 probably has to be added. Similarly, if you are over plused him, also he will be still N6. If you take it backwards by 3 inches and he cannot see it, that means he has been over plused or he has been over corrected. If somebody, because it happens that some patients with +1 also read N6, with plus 1.5 also they read N6, +2 also they read N6, which one to be preserved? So when he cannot see a reading material 3 inches away from the working distance, then that is the time that probably he has been over corrected. So that means able to see over a range across the working distance is the best bet to have the right correction. I think this is so important because the near vision for a presbyope is extremely important. The comfort is extremely important. The amount of it's a very cost intensive progressive glasses. So obviously he can't have too many of them. So this is something extremely crucial when you are actually writing a prescription. So writing a prescription comes with a lot of accountability and the understanding of all these physiological variations in a patient. But very well compiled and excellently presented.
Yeah, great, sir. Krishnavasa, sir. I've been listening to you now for the past too many years. And the last week also, I listened to your subjective diffractions. Really, it was fantastic. Now, Madam has excelled in this lecture. And it's a really great opportunity for us to learn at this age. Thank you very much, sir.
Thank you, sir.
Okay, so thank you so much again. So we'll move to the next topic of today's session. So I invite Dr. Pradeep Kumar Saraf.
Hello.
Yes, sir. Hi.
Yeah.
So
Hi.
I invite Dr. Pradeep Kumar Saraf to
Yeah.
deliver his lecture on approach to a patient in OPD.
Okay. Mhm. Good evening, respected faculties and colleagues. Today I will be presenting the topic approach to patient in IOPD. There is no conflict of interest. A structured approach improves diagnostic accuracy and help patient management. Welcome the patient with the smile and warmth. Please note name, age, sex, and occupation of the patient. Our discussion will follow stepwise outline to approach a patient, starting with history taking, followed by general examination, visual assessment, external examination, slit lamp examination, IOP assessment, and fundus examination. History taking is a cornerstone of any clinical evaluation. It includes chief complaints, history of present illness, past ocular history, medications and allergies, systemic history, occupational history, family history, and personal history. Chief complaint is the main reason why the patients come to see you. It may be symptoms as vision loss, redness, pain, discharge, watering, extra. He may have come to you because he was diagnosed cataract, diabetes, or glaucoma elsewhere, or is in follow-up case of glaucoma, and he may come to you for a routine examination. In present illness, we must note affected eye, it is right eye, left eye, or both eyes, where the problem is located. Onset is sudden or gradual. Duration is days, weeks, or months. Severity, mild, moderate, and severe. We must record pertinent negative questions as in red eye if associated with watering and discharge extra. Let us give an example of history taking in a case of loss of vision. First, we must ask, is it one eye or both eyes? If it is one eye, if both eyes, did it happen at same time or one eye at first? When did it started? How long it has been going on? Is it progressing, improving, or stationary? Is it constant or does it come and go? Few seconds for minutes, or as in amaurosis fugax, dry eye also causes blurring of visions occasionally. Is there any pain or discomfort? And have you had recent trauma? In red eye, we must see some important features to elicit the history from the history. Contact with others with similar symptoms likely to be a viral conjunctivitis. Severe deep pain may suggest acute glaucoma or anterior uveitis. Contact lens wearer may develop corneal ulceration. Presence of systemic symptoms, example, joint pains, suggest generalized inflammatory disorders. You must ask past history, ocular history of the patient. If they use glasses or contact lenses, how old is the prescription? Do you have any known eye conditions at cataract, glaucoma, retina problems? Have you had any eye surgeries or procedures, including lasers or injections, and history of any eye injury? We must know what medications the patient is taking for the eyes. Is example, if they take steroid for a long time, it may lead to glaucoma. Patients may be on anti-glaucoma medications and may not tell you, and you may misdiagnose the case. You must also know about the systemic elements. Medicines taken for systemic ailments as steroids for a long time may lead to cataract, glaucoma. Anti-tubercular medicines, ethambutol, may lead to optic neuropathy, and duration of intake is also important. We must know about the allergies to the medicines. As phenylephrine drops allergy, if it's known, you should avoid it in next visits. Systemic medications as acetazolamide should be avoided in cases of patients allergic to sulfur drugs. We must know systemic diseases which may affect eyes as diabetes, hypertension, thyroid, autoimmune diseases, which may affect treatment as asthma. In that cases, beta blockers should be avoided. Occupational history is important as people in IT industry with more computer use get computer vision syndrome, eye pain, watering, extra. Family history is important in cases with congenital cataract glaucoma. Personal history as smoking and alcohol intake may lead to toxic amblyopia. Begin with general inspection, starting with inspection of face, head posture, globe position, ocular motility and squint, eyelid and adnexa, and pupil. Blister on the face suggests herpes zoster. Scar suggests previous injury. Head posture tilted in superior oblique palsy, left tilt due to right superior oblique palsy. In Sturge-Weber syndrome, you see facial port wine birthmark along with glaucoma. In golden hair syndrome, we see facial asymmetry, underdeveloped ear, preauricular tag with bulbar dermoid and small or missing eyes. Then we must see the globe, its location, its deep set, if it's anophthalmos, proptosis, or dystopsia. Deep set globe is an eye that is more deeply recessed in the face than is normal. Anophthalmos is a condition where eyeball sinks inward in the eye socket as in fracture floor of the orbit. Proptosis is forward position of the eyeball, commonly called bulging of the eye, which is seen in cases of Graves' disease, orbital cellulitis, or mass behind the eye. Dystopsia is a malposition of the eye or bony orbits surrounding it. Mostly it is because of trauma, it may be congenital, it may be because of tumor or some post-surgical. Then we see for the ocular motility and squint. The Herzberg test is done to check for the eye misalignment by shining a light into the patient's eye and observing where the reflection lands on the center of the cornea. In this case, the light reflex is falling in the center of the cornea, so it is normal corneal reflex. But in this case, it is falling outside pupil, it is esotropia. And in this case, it is falling inside the pupil, it is exotropia. It is on the lower end, it is hypertropia, and it is upper end, it is hypotropia. Then we examine for ocular movements in all 6 gazes. It's helped to identify cranial nerve palsies or mechanical restrictions. Next, we examine the lids. Normally, upper lid covers approximately 2 mm of cornea and lower lid just opposed to the lower limbus. In the lid, we must see for the ptosis or drooping of the eyelids, which is mostly congenital. Acquired, it may be because of aging, third cranial nerve palsy, Horner syndrome, myasthenia gravis, trauma, and post-surgery. Post-cataract surgery, sometimes you get ptosis with no obvious cause. We must see for the lid retraction, which is common in Graves' disease. We must see for the entropion, which is mostly senile. And we must see for the ectropion, which is because of injuries with scarring. We must see for the trichiasis by misdirection of the eyelashes and lacrimal drainage system if it is inflamed or not. Next, we examine for the pupil. In pupil, we see the size and equality, the shape, light reaction, direct and indirect, and other abnormalities. An isochoria or unequal pupil size more than 0.5 mm may be found in normal subjects. Unilateral small pupil is found in cases of keratitis, uveitis, Argyll-Robertson pupil, Horner syndrome, and on pilocarpine use. Unilateral dilated pupil is found in cases of traumatic mydriasis, topical medications, oculomotor nerve palsy, and Holmes-Edis syndrome. Irregular pupil shape is commonly seen in cases of uveitis, post-surgery, traumatic sphincter rupture, and coloboma of eyes. Normally, pupil size is dependent on total perceived light reaching the brain. When a flash of bright light falls onto one eye for 2 to 3 seconds, both pupils should constrict, then rapidly move to the other eye for the same time. Normally, both pupils remain constricted. If once the light is moved from one side to other, the pupil dilates. This is abnormal and represents a relative afferent pupillary defect. The pathology is in optic nerves, as in retrobulbar optic neuritis. Polychoria is a condition where there is more than one pupil. It may be congenital. Keratoopia is ectopic pupil. It may be congenital or traumatic. Next step is to see the visual acuity. Visual acuity testing is a fundamental and must be performed for both distance and near vision with and without correction. Use the pinhole test to distinguish refractive errors. When relevant, assess color vision and visual fields to detect optic nerve or retinal pathology. Vision testing is done mostly by Snellen's chart or Logman's chart. Later is more accurate because they have same number of letters in each rows and it avoids overcrowding as is seen in Snellen's chart. If acuity is so poor that the patient cannot see the top line of the chart, then assess at 3 meters, ensuring that this is documented at 3 by x. If no letters are seen at shorter distance, the next step is to assess ability to count fingers, regarded as counting fingers. If finger counting fails, then assess ability to perceive hand motion. Finally, if unsuccessful with the above, assess ability to perceive light perception if the patient can see the light and he can see the direction of light where from the light is coming, that is PR. Objective refraction, it gives the approximate refractive error and it is done by automated refractometer and retinoscopy. It can be used to prescribe glasses in illiterate and special persons not responding to subjective refraction. Subjective refractions give the final correction and is prescribed in the glasses. Cycloplegic refraction is a procedure using eye drops to temporarily paralyze the accommodation, allowing for more accurate measurements of the full refractive error. In this case, retinoscope is preferred over automatic refractometer. This is crucial because children's strong accommodation can mask underlying vision problems like latent hyperopia or pseudomyopia and is recommended for identifying conditions as amblyopia and squint. Color vision test in outdoor is done by Sierra chart. Color vision defect is mostly congenital, but acquired defects can be seen in chronic illness as Alzheimer's disease, diabetes mellitus, glaucoma, leukemia, etc. Drug toxicity as ethambutol and chloroquine can also lead to color blindness. Assess conjunctiva, cornea, anterior chamber, pupil, and iris and lens. This is done preferably by slit lamp. Basic inspection often guides diagnosis. In conjunctiva, first we must see for congestion. It is redness of or prominent blood vessels. It may be generalized as in conjunctivitis. It may be localized injection is seen in cases of scleritis and episcleritis. It may be circumciliary congestion around the cornea and is seen basically in cases of keratitis, glaucoma, iritis, and other diseases. In conjunctiva, we must also see for pterygium, pingicula, Bitot spot. Subconjunctival hemorrhage, papillae and follicles. For that, you have to evert the upper lid. After conjunctiva, we examine for the cornea, the neck structure. The size of cornea, if it's small, less than 10 mm, is microcornea, and it's more than 13 millimeter, it is megalocornea. The shape of cornea, if it is conical in shape, it is keratoconus, and is globular in shape, protruded out, it is keratoglobus. We label opacities in the cornea, and it is nebular, macular, or leukomatous depending on the density of the opacities. Nebular opacities is very fine and difficult to detect. Macular opacities are the easily seen, and leukomatous is very dense opacities which can be seen from distance. Then we must see if there is corneal neovascularizations, if it is superficial or deep. This is superficial vascularization, and these are the shapes for the deep vascularizations. Superficial vascularization involves the epithelial and subepithelial layers, while deep vascularization penetrates the stroma, the deeper layers of the cornea. Fine branching appears in superficial vascularization, fine branching and appears as spanners of web-like growth, while deep vascularization vessels are more often straight, dense, and brush-like or arcade-like. Superficial vascularization is more common seen in contact lens wearers, blepharitis, conjunctivitis, or other irritants, while deep vascularization is linked to more severe conditions like chronic inflammation, interstitial keratitis, or deep corneal ulcers. Superficial vascularization is generally considered less threatening, maybe still causes irritation, but often remains benign, while deep vascularization has higher risk of vision-threatening complications as stromal hemorrhages, scarring, and lipid keratopathy. Then we see for the corneal sensations, which is reduced in ocular or systemic disease as herpes keratitis, simplex or zoster, diabetes mellitus, neuropathy, and myasthenia gravis, extra. Corneal surgeries, especially corneal refractive surgeries like LASIK and PRK, also causes a reduce in corneal sensations. Next, we see for the corneal edema, the thickening of the cornea, and is mostly seen in cases with acute congestive glaucoma, Fuchs endothelial corneal dystrophy, causing bullous keratopathy, and post-surgery. We must also see corneal by fluorescein stain for any ulcer and foreign body. After cornea, we see for the anterior chamber depth. This is determined using a slit lamp to compare the width of light beam shadow in anterior chamber with thickness of cornea at its periphery. Von Herrig grade 4 indicates that anterior chamber depth is equal to or greater than corneal thickness, suggesting a wide open angle. This is wide open angle, and in this closed angle where you don't see any opening. In anterior chamber, we see for the flare, hypopyon, and blood. Flare suggests uveitis. Hypopyon is white blood cells in anterior chamber forming a visible whitish layer at the bottom. It is sign of severe intraocular inflammation or infection and requires urgent medical evaluation as it can be caused by serious conditions like uveitis, keratitis, or endophthalmitis. Hyphema is accumulation of red blood cells in the eye's anterior chamber, It caused by trauma, iris neovascularization, post-surgery, bleeding disorders as leukemia and hemophilia. Then we see for the color of the iris, atrophy, pseudoexfoliation, and defects or coloboma. Heterochromia is a condition when the color of two iris are different. It may be in same eye, you may have the different colors, or two eyes may have different colors. It may be congenital or acquired or drug-induced as by latanoprost. Atrophy and coloboma of the cornea of iris should be seen. It's most commonly seen in cases with iodocorneal endothelial syndrome. It may be after surgery or any injury. Pseudoexfoliation eye syndrome is a chronic age-related condition where a flaky dandruff-like material builds up on front part of the eye, particularly on the lens and the iris. Then we must examine for the lens, its transparency, position. If it's pseudophakic, then IOL position and posterior capsular thickness. Haziness of lens is known as cataract. If the lens is not in the position, is subluxated, and if it falls away from the pupillary area, is dislocated. It's mostly seen in cases with Marfan syndrome and trauma. In pseudophakic eyes, again, we must see if the lens is in normal position or not. And what about the posterior capsular thickness? Because thick posterior capsule cause reduced vision. Then we examine for the IOP, intraocular pressure. IOP is measured by applanation tonometer, non-contact tonometer, and Schiot's tonometer, and other tonometers which are available. These three are the most common tonometers available. Applanation tonometer is more accurate. Non-contact tonometer is used for general screening, infection cases, and non-cooperative patients. Schiot's tonometer is now rarely used but can be used for screening and when the corneal surface is irregular. Gonioscopy is done when suspect narrow angle of entry chamber as seen by von Erich's method or in suspected cases of glaucoma. Must be done before dilatation of pupil for fundus examination. Finally, we examine for the fundus. Complete fundus examination needs pupillary dilatation. Do not dilate pupil before doing slit lamp examination and IOP checkup, as dilatation of pupil may aggravate acute congestive glaucoma in suspected cases. You may miss important findings as PI, eyes neovascularization extra, if you dilate the pupil without doing the slit lamp examination. Fundus examination is done to evaluate optic disc, macula, vessels, retina. It is done by using direct or indirect ophthalmoscope or slit lamp with 78 to 90 diopter lens. Indirect ophthalmoscope is good for peripheral retinal evaluation, while slit lamp examination is good for disc and macular evaluation. In disc, we must see for the size, color. Pale disc suggests optic atrophy. If the margins are blurred, it suggests disc edema. And cupping of disc, we must see for glaucoma and optic disc pit. Just normal disc, glaucomatous disc with large cupping, optic disc edema with blurred margin, optic atrophy, the pale disc. In fundus examination, we must see for the retinal holes and lattice degeneration, retinal blood vessels, hemorrhages and exudates, pigmentation, retinal detachments, and tumors. Retinal holes, we must see lattice degeneration is seen like this. Retinal blood vessels, and we must see for encalibur and sheathings. The sheathing is most commonly seen in inflammatory conditions, examples, Eales disease, sarcoidosis, Beckett's disease, vascular disease as hypertension. Hemorrhages or exudates are seen in cases of retinopathies as diabetic, hypertensive, and leukemia. Retinal pigmentation is seen in cases of retinitis pigmentosa, choroiditis extra. No pigments is seen in cases with albinos. We must look for the retinal detachment and tumors as in choroidal melanoma. Next, we examine for the macula. In macula, we see for the drusense, hemorrhages and exudates and degenerations. These are the drusense, white spots, white yellowish spots. Hemorrhages and exudates as seen in cases of diabetes, macular edema, ARMD. We must see degenerations as Stargardt disease. C for the haze, hemorrhage or any other opacities. Example, 40 years old presents with painful red eye and photophobia. The differential diagnosis is conjunctivitis, keratitis, uveitis, and glaucoma. In conjunctivitis, there is discharge, mild pain, and more of irritation. History of many fembers involved. In keratitis, pain is severe, decreased vision, corneal irregularity, and haze is seen. In uveitis, pain is severe, associated with photophobia, decreased vision, small pupil, aqueous flare, and capes. While in acute congestion glaucoma, there is severe pain with headache, with or without nausea and vomiting, halos, corneal edema, mid-dilated pupil, and raised IOP. So by history and examination, we can diagnose the case. In this, we take the history of pain, severity, it is unilateral or bilateral, vision, pattern of redness, pupil size, and corneal clarity. All this helps to diagnose the cases. Second case, sudden loss of vision in case of diabetics. 60 years old diabetic with sudden painless loss of vision. We must consider vitreous hemorrhage, retinal detachment, central retinal artery and vein occlusion, and optic neuritis. Urgent fundus examination and cystic workup is required to differentiate the case. Case 3 is sudden painful loss of vision. Is considered keratitis and corneal ulcer, acute anterior uveitis, acute congestive glaucoma, endophthalmitis, and retrobulbar optic neuritis. Keratitis and corneal ulcer has severe pain, decreased vision, corneal irregularity, and haze. If corneal ulcer is exposed to vestibular injury, more likely to fungal. So you must ask how you got the injury in the corneal ulcer. Fluorescence stain shows the ulcer. Acute anterior uveitis may have severe pain, photophobia, decreased vision, small pupil, aqueous flare, and capes. Acute angle closure glaucoma, severe pain with headache, with or without nausea and vomiting, halos, mid-dilated pupil, and raised IOP. Endophthalmitis, there is severe pain post-surgical or systemic infection. There is loss of vision, sudden onset, cornea may be involved with hypopyon and vitreous haze. In retrobulbar neuritis, there is sudden loss of vision, pain on ocular movement, RAPD, and no other ocular findings. The sequence of evaluation can be remembered as history, vision, external eye examination, slit lamp, IOP, fundus examination. Then we do the diagnosis and plan for the treatment. Investigations are guided by clinical suspicions and are often integrated in ocular disease assessment. If required, we have to do the visual field testing, fundus photography and fluorescent angiography, OCT for optic retina and optic nerve, B scan, ultrasonogram, systemic tests as blood sugar, BP and thyroid. Key take-home message. Always start with proper history and systemic examination. Examine in sequential order from front to back. Do not assume every red eye is conjunctivitis. Examine thoroughly. Differentiate between painful versus painless vision loss. Maintain a systemic, repeatable approach. Document finding clearly. Communicate effectively with patient regarding the diagnosis and follow-up. Thank you.
Thank you. Thank you so much, Dr. Saraf. So the
Really,
discussion by expert panel can go ahead now.
Saraf sir, really fantastic
Again, if you
lecture.
want to add, yeah.
And you have added so many points. Only one point I want to add. When you're in outpatient department, you see small girls are brought to you with some black pigments in their conjunctiva. And as you know now in India, the normal habit is what? Applying surma or kajal. This kajal can get adhered to the dry conjunctiva. Naturally, the problem is the dryness, like you told about white hot spot, conjunctival cirrhosis. Here, the kajal black spots in the conjunctiva in young girls in our country. We have to be careful about the vitamin D deficiency. If it's a wet conjunctiva, it is washed off. So always we have to remember black spots in conjunctiva of small girls in our country. We have to think about vitamin D deficiency. We have to start. Otherwise, they are going to go in for future problems. This is called as, I think for my exam purpose for the postgraduates, it's called as IMTIAZ sign, IMTIAZ, IMTIAZ sign. Thank you very much, sir.
Thank you, Dr. Saraf. I think it's been a real a basic class covering almost everything. I think a postgraduate who has just joined PG should be actually listening to this because he gets a complete 360-degree of ophthalmic, OPD, what to look for in a patient who comes with a problem. I think my 2-3 things for a postgraduate, I think everybody wants to be a good clinician, should be successful in our clinical practice. So communication is very important. So there is no curriculum for communication. Everybody is gifted by themselves, and the PGs have to actually look at the experienced clinicians like Dr. Saraf, Dr. Vijay Raghavan, Dr. Uma Kulkarni. They should look at their teachers, mentors, and try to understand how they actually get the history out, and they go back and forth from examination to history once again. Because many of the PGs think that first they have to take history, then examine in a particular order. When they present a case, they normally think that first history is always done, then examination. It is not like that. In clinical practice, we go back and forth. When somebody says a chief complaint, I have some 5 things in my mind. I ask few relevant questions, 3 things will go away. I look at the eye, again come back. Maybe I look at the eye once again, I have some more question to ask. So basically the final differential diagnosis that you arrive at is basically a result of going back and forth mentally between what are all the possibilities. Normally, an experienced practitioner will have less DDs. But a new PG will have only one diagnosis. They don't have a DD because they know only one thing. So everything, whatever they have read on the previous day, will appear as if that is the only diagnosis. So they normally either have the too many things they know or they know only one thing. But it is important to come to an appropriate diagnosis, and it is very important to go back and forth from the right relevant questions, and also doing the examination, and finally bringing it together to have a differential diagnosis or maybe a single diagnosis also. And one more thing which I normally want to emphasize is one simple thing. Normally people have media opacities. It may be a corneal opacity, it may be a cataract, it may be a vitreous hemorrhage. So there is a vision loss. Normally, the best thumb rule is always try to understand whether the amount of vision loss should always commensurate with the amount of cataract. Normally, cataract is what they see. So a lot of people will say very early cataract, the vision is only hand movements close to face, and they think it is due to cataract. So once you probably refract a patient of cataract, what is the best corrected visual acuity? It should always match the amount of cataract. I think this one simple thing can save them, because the patient may have a macular hole which may not be very discernible through a hazy media. Patient may have an optic atrophy. So there may be some problem at the back. And just if you know that the vision is too low for this amount of cataract, this can be a warning bell for them to really look into the eye more carefully. And I cannot overemphasize the importance of pupillary examination. I think RAPD is one objective test. No device and no examination, no investigation can compare anywhere close by. RAPD is such a excellent, elegant tool, which is an inbuilt control. That is something that always tells something is wrong. You can't have an RAPD and have a normal eye. So, and it may not be linked to the vision also. Actually, a eye with a better vision may have an RAPD. So, it is RAPD is always abnormal, and not seeing the pupil properly or dilating the patient without looking at the pupillary examination is a big sin. So I insist on all youngsters to understand the importance of RAPD, and no investigation can actually replace a pupillary examination. I think these are my opinions that are very important, that they should be practicing in future for a very successful practice. Dr. Uma.
Exactly. I wanted to emphasize the same thing. There are some common mistakes that many postgraduates do in the OPD. They straight away go for slit lamp examination without holding the torch in the hand, without looking at the eyelids, conjunctiva, cornea, pupillary reactions. So the first thing they do is straight away go for a slit lamp examination. I think that should be avoided by every examiner, every student who is examining, or every consultant who is examining. Second thing is, once they dilate the pupil, the first thing they do is IDU. Straight away go to the retina and examine the retina without examining the androus segment. Many things would have changed. You would see some pigments on the lens, a pseudo exfoliation. So many things will be missed if you don't examine the androus segment once the pupil is dilated. I think these are very important points. Third thing is, again, sir has already mentioned the importance of looking for RAPD and pupillary reactions in every single case, whether or not you are expecting some optic nerve pathology or retinal pathology. I think it's very, very important to look at. And examination of a red dye before dilating, because once you dilate, the redness will, the congestion, superficial congestion will completely go. Examination of ptosis cases before dilating the pupil, because even that can give rise to a wrong finding, or you might miss some findings later. So I think the order of in which examination has to be conducted, one test after the other, dry eyes, whether it comes to dry eyes or examination of corneal ulcer, looking for corneal sensation before staining and before doing other tests, so important. I think this cannot be overemphasized, the order in which you do, and not miss the torchlight examination, not miss the pupillary reactions, and androus segment examination after the pupil is dilated. I think these are some takes from my side.
Okay. Dr. Vijay Raghavan, sir, do you want to add something? You are muted, sir. Can you please unmute yourself?
And before doing, the fundus examination, they can do what is called distant direct ophthalmoscopy. Of course, now we are not using distant direct, but by chance you have got a capacity, that is, if you are able to do that at a distance of 25 centimeters, you can see the media whether it is clear or not. It's the most important. Best way in the outpatient department itself, we can see if you find some opacity is there in the media, ask the patient to look up and down. If the opacity moves with the movement of the eye, that is in front of the pupillary plane. If the opacity something is there, it is moving against the eyeball movement. It is behind the pupillary plane. It's not the nodal point. It's the pupillary plane. This is called method of parallax, or displacement by parallax method. This also they can do, so that they can identify the opacities in the media. That's what I want to tell. Thank you very much.
Thank you, sir. Dr. Kavita, ma'am, you wanted to add something regarding the extraocular movements and deviation?
Yeah, many times I think, as Dr. Uma mentioned about ptosis, Uh, many directly we go to cornea and cataract because the other things and all are forgotten. Right from facial symmetry, ptosis, even mild ptosis is missed. Along with the lid, callus is missed. So they are attacking only cataract now. So they forget callus also. So if they are missing callus, I think they will definitely miss phorias and deviations and even limitation of movements. That is also missed, or a long-standing nerve palsy is missed. So
I
the
think I
method
can't
of
agree.
examination.
Absolutely right, Dr. Kavita. In this month only, I just picked up two proptoses. The patient has been seen by all my fellows and PGs, and the patient actually has proptosis,
Mild
mild
proctors,
proptosis,
they would
because
have
I've never
missed
looked at the patient's face at all. And I looked at the patient, I said something is abnormal. Then we go in. They were directly, as you said, they directly reach the internal
cataract,
limiting
the
membrane.
bread and butter. Cataract.
One more
Okay,
thing,
just
sir.
one last question, sir.
One more thing.
Uh,
Farnas, just one point.
sure.
So when you ask the patient to do the movements and all, when you examine, don't hold the lid and see the movement because there are some chances the lid may give us some clue like Duane syndrome and all, lid lag and all. Always ask the patient to move, but don't hold the legs. I have seen so many students doing like that. So I used to advise them not to hold, otherwise they will missing the Duane syndrome and they will unnecessarily get failed in the exams. Thank you.
Thank you, sir. Just one last question. I would like to ask this to Dr. Krishna Prasad, sir. So, can you um, tell us, like, what are the most common mistakes residents make in this area of refraction, especially during the time of Viva?
Okay. I think I have been overemphasizing on this that refraction is something which cannot be taken lightly. I think every PG understands, and that is why it has been their nightmare because the examiners know it too well. Number one. Number two, refraction is a part of quintessential part of every subspecialty. And whenever they go to practice, whatever their lapses in the refraction knowledge will haunt them very badly. So I think what is very important is to understand the very basics that there is what is called an objective refraction. Like you give a patient, and with what techniques you identify the refractive status of this particular eye. So, what are the methods? It may know it can be a retinoscopy. What are the principles of retinoscopy? How the reflex moves, and how you have to put different trial lenses to neutralize it. At what distance, and how do you arrive at that retinoscopy findings, and how to extrapolate this information into a subjective refraction. You have to start putting lenses on a trial frame and see that the patient gets that best corrected visual acuity with the appropriate correction. This is a science and an art. I think what I say is it is not a theoretical thing. You can't sit in your room and master refraction. You have to be in the field. I think it doesn't require a patient. No, you can actually have a volunteer. Your lot of your colleagues, your students, anybody can be your volunteer. Try doing refraction on each other. And every subjective, see, we are not asking you to give a peribulbar block. Okay. Okay. It is just all this subjective. Dr. Natasha told about cross cylinder, astigmatic dial, binocular balance. You can have a volunteer and you can do it on yourself and see what really happens. So that is where most of the students, and I see sometimes they come to the exam without having even done even it once. They are seeing it for the first time in the exam. I think don't do that. I think it is not for exam. I think this fear of exam is completely unfounded. You don't have to really create this scare of exam for them to learn refraction. The patient sitting in front of you in your practice is your biggest examiner.
Mm.
Okay, your examiner may not ask you refraction, but the patient sitting in front of you who says you can't give me a right glasses because patient thinks doing cataract is difficult and giving glasses is easy, which is actually the reverse for most of us, right? So this is a very basic skill and we have to master it at any cost and please do it yourself to master it. There are always enough resources. Don't wait for the exam to happen. At the very beginning of your PG course, I think you should become adept in doing your refraction.
Okay. Thank you so much, sir. So, Dr. Vikas, he couldn't join us today because of technical issues from his side. So, with that, we come to the end of today's session. And thank you so much for joining us, all the speakers and also the expert panelists. Thank you so very much. So, we'll see you again tomorrow morning 10 to 1 p.m., 10 a.m. to 1 p.m. for the next session on examination techniques. And yeah, that's it. Have a great weekend. Good night.
Thank you,
Thank
Rolika,
you.
Farnas. Had a great time. Thank you. Thanks,
Thank
everyone.
you.
Good night.
Good night.
Shabazadar, good night. Madam, good night. Good night.
Thank you. Good night.
Thank you. Thank you.